Dear friends and colleagues, we are here in Lisbon. We enjoy a very friendly and warm atmosphere. We are attending the largest international congress on malignancies in the elderly, the yearly congress of SIOC. SIOC is the International Society of Geriatric Oncology. We had a lot of interesting presentations within the last day. Nearly 400 delegates from all around the world. One of the most fascinating fields in oncology is chronic lymphoid leukemia, or CLL. CLL represents the most frequent hematological malignancy in the elderly. Within the last years, we have had a lot of fascinating developments which might result in treatment concepts where we apply effective therapies using approaches which do not contain chemotherapies any longer, which means there are kinase inhibitors, there are new antibodies, there are agents directed at BCL2, blocking apoptosis, or immunomodulatory drugs, which are well tolerated and highly effective in elderly. Today we had a session dedicated to CLL. Two high-ranking specialists in the field were giving their talks and contributions, and I would like to welcome them today. They will report their results, their conclusions. I'm honored to have Dr Morrison from the United States, Minnesota, and Dr Cruz-Jentoft from Madrid, Spain. I am the CIOC representative of Austria. Vicky, you gave us today an overview on supportive care in CLL because progress in outcome of elderly patients does not only rely on the development of new drugs, but also on improvement in supportive care. So how would you summarize the most relevant developments in the last years?
Certainly, infections in patients with CLL are of paramount importance. These patients are more prone to infections because of the immune defects related to their disease, as well as the therapy that's given to these patients. Because of the disease process itself, patients with CLL very prominently will have hypogammaglobulinemia, which is more common at the longer that they have the disease or the more advanced stage of the disease is. Likewise, not as well known, is these patients also can have defects in cell-mediated immunity related to the primary disease process, as well as in complement activity. So even without any treatment, there's many patients with CLL who may not be on therapy, but these immune defects are there. That's further complicated by the types of treatment that we give to these patients. Some of the treatments that we use, for example, the purine analogs, alemtuzumab or Campath, can cause defects in cell-mediated immunity that actually occur very early in treatment, often in the first several months of treatment. And so one needs to be aware of those defects so that appropriate antimicrobial prophylaxis can be given. If one looks at preventive approaches in these patients, the use of intravenous immunoglobulin or vaccinations, or even antimicrobial prophylaxis, unfortunately, there's not a lot of prospective randomized clinical trial data, and most of the recommendations are based upon the impact of these agents on the immune milieu, as well as what's been reported in what clinical trials are out there, whether it's in the United States or in Western Europe. We know that with agents that cause defects in cell-mediated immunity, like the purine analog, specifically fludarabine, but also alemtuzumab, with fludarabine we know we can see more herpes virus infections in terms of herpes simplex or varicella zoster infections or herpes zoster infections. CMV becomes a bigger issue in those patients who are receiving alemtuzumab. In terms of what infections occur with the use of some of the newer agents, whether one uses bendamustine, ibrutinib, or idelalisib, certainly the data there is a lot more limited. With the clinical trial data with these newer agents, that have been reported in CLL patients, there does not appear to be any mandates that specific antimicrobial prophylaxis with these newer agents is needed. On the other hand, we will have to await further use of these drugs to see if any infections may potentially emerge. But at this point in time, it appears with the newer agents that we don't need to use any specific antimicrobial prophylaxis.
Mm-hmm. Summarized your recommendations for up-to-date, and I think also in other journals the readers can or colleagues can look it up.
Yeah, the up-to-date document will probably be on their website fairly shortly, probably within the next several months. That very tersely summarizes these antimicrobial prophylaxis recommendations.
I mean, actually many patients will ask you, what's about influenza, what's about vaccination, what's about flu shots, so what's your recommendation?
Generally, we like to give them yearly flu shots. Certainly the impact on especially morbidity of getting influenza is significant, and we usually do recommend influenza vaccinations for these patients. In terms of pneumovax, that's also recommended. Zostavax was approved in the United States only about 4 to 5 years ago for older patients to prevent the occurrence of herpes zoster, but this vaccine was studied basically in healthy adults that were older, at least 60 years of age, that did not have any known underlying malignancies. So there are new preparations of Zostavax. There's an inactivated vaccine. There's another company also making a recombinant Zostavax vaccine that is presently undergoing study in patients with malignancies. But at the present time with Zostavax, it's technically not approved for patients with CLL.
Thanks a lot. Dr. Cruz, you are one of the leading specialists in geriatrics in Europe, which is underlined by the fact that you are the former president of EU GMS. You have a dedicated program which focuses on individualized treatment decisions in CLL at your institution in Madrid. Could you explain to the audience how your individualized treatment algorithms are developed?
The first message is that CLL is not the single only problem older people have. When you have an old patient, CLL is one of the very many problems he or she may have, and that includes other comorbidities, includes physical problems, mental problems, social problems, depression, and other. So for advising patients properly, you need to assess all this in order to choose what's the best way to manage for the management not only of the CLL but also of the rest of the diseases. Usually hematologists and many other oncologists are looking for a classification because those who are very robust, that means they can receive any therapy as if they were younger. Those who are very unfit or very sick, those who usually only need palliation. And then there's an in-between group called frail. That's the critical group for geriatricians at least. It has to be very clear that this name of frailty is not the same in the oncology and the geriatric literature. Mm-hmm. Usually in the most recent geriatric literature, frailty is a concept to define vulnerability to disease or to disability, but this is people who you will consider robust. The second concept of frailty, based on a concept developed by Rockwood, is accumulation of diseases, and that's closer to what's being used in oncology. People who already have diseases and disabilities, but not to the extent that they are so relevant as to need palliation. The important point in identifying this is that some of these items can be changed or improved together in parallel with cancer treatment and with CLL treatment. So it's not only a matter of searching and identifying very well and using that to advise the person, but also to improve some of them if feasible. The second issue I talked about is that we don't still have good instruments to do this classification in CLL. There's a multi-center measurements for scales, that's reliability, external and internal validity, and all these kind of steps that have usually not been performed in cancer CGA scales. So we're starting from the beginning, and we hope to have data in future years developing a specific scale for chronic hematological malignancies.
Mm-hmm. Because you're not only developing your scores on CLL, but also on MDS, AML, multiple myeloma.
Yes, that's also, first it's important because there are no scales and they're all chronic hematological malignancies. The second is using these three groups that are usually equivalent in size will allow us also to check what are the main differences, and we will learn if each single disease needs a specific change in the instrument of us, or a single instrument may help all of them when you use it for decision making.
Do you feel that the new drugs will overcome some of the classical parameters which predicted toxicity or clinical outcome? Because in the and when you used fludarabine containing regimens. But nowadays you have new drugs like idelalisib. So what's your general opinion concerning the relevance of these risk parameters or these parameters to classify patients under the aspect of new drugs? I know it's a sophisticated question.
Yes, and I'm not an expert in new drugs. I think things will change, but my major concern there is they're not being studied in the proper patients. In most of the studies of these new drugs, the patients I'm talking about, most of them will be excluded by any exclusion criteria. And this is shown repeatedly, not only in this disease, but also in cardiovascular diabetes and other. So the main question here is, how will they work in real practice when we apply them to a population that's not been included? In fact, this is so important that now the European Medicine Agency has a program where they want to include information on frailty, comorbidity, nutritional and mental status in all clinical trials. To choose what's the drug better tested for those difficult populations.
I mean, that has been a challenge so far, that about 70% of elderly were excluded from clinical trials, and quite often they were excluded based only on age. I mean, a relevant proportion was excluded based on performance status and on comorbidities, but a proportion of 30% was excluded only based on the age, which contradicts the principles of geriatric oncology. So your approaches are certainly highly appreciated.
There are some groups, both in the European Medicine Agency and external groups, working in fighting discrimination in use of drugs, and there's even in Europe a charter of rights for the people in their access to clinical trials. It's called PREDICT, and it's written, you can find it in the website. It's a European project.
And what's about the implementation of PREDICT? Because I know it, I think, since 2 or 3 years, but
it's very slow. The first specialty who started fighting discrimination are cardiologists, in fact. They found this 20 years ago, and there's been a shift towards including more older patients and more frail patients in trials, but this is not yet happening as far as I know in oncology or in hematology. Even in diabetes, we recently published that more than 70% of the trials that are now not finished, ongoing, will have some discrimination by age or by morbidity or by physical function. So the new drugs, even in such a common disease as diabetes, will not be fit for these frail people. So it's not only a problem for this disease.
Okay, I think CLL is a very fascinating disease. I mean, it's the most frequent, the most common disease in the elderly. We have a lot of new drugs, so I have the feeling we have a kind of hype in CLL. There's a lot of high-ranking publications, a lot of new drugs. I mean, it will be fascinating to combine some of these new drugs, for example, kinase inhibitors and monoclonal antibodies, to improve outcome. And the basis for the treatment should be individualized decision making based on geriatric assessment.